So while we're doing that, let me introduce Dr. Daniel Donoho, one of the neurosurgeons at Children's National. And you want to say anything or
Yeah.
sing something? While we're,
No one needs me to sing. Thankfully, I'll just. My son is actually getting. It's a very nice talk from Dr. Newman. My son actually is just getting his COVID vaccine right now. He's 22 months old, so his mom and I are really excited. And then the rankings. I was at Texas Children's last year, and so at that point, Texas Children's Neurosurgery was number 2. Of course, unfortunately, my wife is a neonatologist, so she was still ranked number 1. But now I'm here, and she's here, and so I dropped to number 3 in our house. That's okay. My son always comes first before me, anyways. So hopefully, we'll be back up there challenging them soon. So the rankings are always kind of fun between us. So. I guess we're a children's family, so great. So I'm gonna kick this off for a minute here. I wanted to welcome you all here. I'm very excited to see all of you, and I've met some of you before. For those of you who don't know me, I'm a pediatric neurosurgeon here at Children's National. Hasan Syed is one of my partners here and was really instrumental in helping to put this talk together, and he's actually attending the birth of one of his nieces, so that's why he's not here right now. We don't have conflicts. We're not discussing any unapproved devices. This is our group. We're really excited and grateful to have a group of 5 subspecialty surgeons that can each offer something unique for our practice. We're led by Dr. Keating, who's a fixture at Children's National and really ensures excellence and is really a consummate pro at keeping up with the community, and I'm very grateful for his leadership. We offer a complete team approach to neurosurgical care that runs the gamut from non-invasive or minimal access surgery for the brain and cranial-cervical junction and spine, all the way up to conventional open cases. And we do this in a child-centered fashion. So it's not just brain surgery. We perform all manner of procedures for epilepsy, for spine, craniofacial, brachial plexus cases, just some illustrations of some of the things that we do. And we do this at a variety of locations. So I wanted to I'll show a few QR codes. The reason I'm going to do this is actually not for this slide, but for a couple of the slides where I'm citing papers, particularly the AAP series from the Neurosurgery Subcommittee. They're excellent. So they actually link to the papers from the AAP website. So if it's something you're interested in, you can just hold up your phone's camera and it'll automatically take you there. We practice out in the community in addition to being at DC. We're in Frederick, Howard, we're in Fairfax, and Annapolis. So we have kind of very deep roots throughout the greater region. And I've met some of you through this, and we're really excited to expand and continue our outreach efforts, both through giving talks and meeting you all. And of course, Rockville. So, normally when I'm giving a talk about brain tumors or skull-based surgery, we'll show some pretty slides like this that, show a nice surgical approach and some considerations and technical nuances. We're not going to talk about that. We're not going to talk about surgery today. We're going to talk about a bunch of conditions that are somewhere on this continuum. And this is a scale of the probability that you need a neurosurgeon. This is I guess, yeah, so. How much feedback is there? Okay, great, not too much. So it ranges from 100% for a kid that's born with an occipital encephalocele that doesn't really need to be talked about in this forum, all the way down to this poor child who might be about to be eaten by his mom and dad, but other than that is pretty low risk for needing a neurosurgeon. So those are the 2 ends of the spectrum, and we're gonna stay in the middle today. So what's in the middle? These are chief complaints that we all see in the office. I see them, you see them, and they're the trickiest ones that we see because there's not a clear answer. Does this child with sacral dimple need referral? What about this kid with a funny looking head? How do I know? What do I mean when I say that? And how do I make an informed decision? A large head, a small head, gait abnormalities, headaches, an incidental imaging finding. These are really the findings that we're going to confine ourselves to today. So we'll just get started and dive right into it so that I don't get in between you guys and lunch. So these are the ends of the spectrum. On the one end, there's a kid with multiple sacral abnormalities. There's a gluteal cleft that's abnormal. There's a skin tag. There's an underlying lipoma under the skin. That's a kid that if you saw in your office, you would say, look, this, I can get the imaging, I cannot get the imaging. This kid has something wrong and someone needs to evaluate them to see how bad it is. On the other hand, there's the most innocent of sacral dimples, and we'll talk about kind of what the difference is between them and what's lying in the middle. So before we do that, let's talk about a little bit about what's at stake. Why is this an interesting topic? Well, all of these questions happen in newborns. We recently we get increasing guidance about the risk of imaging in newborns, which thankfully at Children's Hospital, we have specialist anesthesiologists and can minimize our duration of anesthesia and the agents that we use. But there's still an inherent risk particularly for procedures, but also for multiple trips of anesthetic to perform MR. So for these kids we're talking about, does this kid need an MRI of the spine with and without contrast, with sedation, particularly if they're over a month of age? So this is definitely a condition where I think it's reasonable to refer the kids prior to ordering imaging, but this is sort of what's the stakes here. What else is at stake? Well, this is the other end of the spectrum. This is from my practice when I was in training in LA. This is a kid who had a sacral dimple. They got a spinal ultrasound that showed, no tethering of the cord. They went along their way, and they came in about at age 2 with a recurrent meningitis, lower extremity weakness, bowel-bladder dysfunction. And they have a purulent, infected dermal sinus tract with now a new neurologic deficit. So they need multiple operations, rehab, et cetera. So this is what we're hoping to avoid by screening patients appropriately. And this is kind of the two ends of the stakes. On the one hand, you get an MRI for every kid. You'll have anesthetic problems. On the other hand, we want to limit the number of these that we'll see in our lives. And that's a culture swab getting the pus out from that kid. So which sacral dimples are dangerous? There's a really nice paper, sort of a guidance document from the AAP and some good neurosurgeons that basically boils this down to one simple sentence. In contrast to what we've been taught about whether or not you can probe the bottom of a sacral or lumbosacral dimple, what you're really interested in is its location. And the more caudal located dimples that are coccygeal in large studies are never communicating with the spinal canal. We'll talk about exactly what I mean by that, whereas the true lumbosacral dimples are concerning. And then this brings us to this sort of simple dimple rule, which again boils down in large part to the location of how low this is. Is it within 2.5 centimeters of the anal verge, i.e. is it really within the gluteal cleft? Is there a normal gluteal cleft? And are there any skin parameters that are abnormal? And those are the high-risk dimples that should be referred to neurosurgery, the ones that are farther away, that are large, or that have high-risk skin features. But location for these is really what we find in our practice. And what do we do when we find these? So the number one thing is to look to see if there's an associated dermal sinus tract or lipomatous malformation. And these are repaired mandatorily. All of these kids get surgery. So the reason we operate on these kids when they're well is to avoid getting a disseminated infection later in life. So that's what that boils down to. So what does the surgery look like? This is a recent case. This is all we saw. So it's obviously in the operating room, so there's no question about the decision-making here. We've already gotten the MRI, but just to highlight the features that are around the surgical incision, there's one single pinpoint area. There's a clear bottom to this tract. There's no question that this is not communicating with the spine to the outside world, but there's also a clear dermal sinus tract that's reaching down to the spine from there. And you can see that it's well above the gluteal cleft, which is shown on the left, and the head of the baby would be to the right. So what do we do for these? Just to give you guys an idea. So we get an MRI that shows the clear sort of communication in that area. It shows the surgical view here when we're lifting this thing up on its pedestal, and then we see the final closure of this. Let me just take a look at one thing. I'm going to pause here. I want to make sure that we're on the this. Oh, guys, I'm so apologetic. These are not the slides. So sorry. Can you give me 1 minute here? Maybe I should switch to my laptop. Is that okay? Yeah, I'm so sorry, guys. Yeah. So sorry about that. Yes. Yeah. Yes. Thank you, guys. Great. Awesome. Sorry about that, you guys. The talks will diverge in a minute. So I wanted to make sure that we just showed this. So the MR here just shows that there's tethering of this tract to the spinal cord. Even if the conus is in normal position, we'll still operate on these. It shows the connection to the skin and shows the tract. And then the operative view there just shows the dural attachment, the skin, and the tract again. And that's the final result. Most of these are dermal sinus tracts, but that's not the entirety of these. Most of the other malformations follow these same rules about location and findings. So whether it's talking about a lipomatous malformation, whether it's talking about a split cord, the precise types and characteristics are, not really the subject of this talk, but as a pediatrician scanning and surveilling for these, this is what we're looking for. That's in a nutshell, the most pertinent sort of early newborn spine question. But what about cranial disorders of infancy? Those basically boil down into three things that we see commonly in our practice: head size, head shape, and cranial abnormalities. The cranial abnormalities we're going to probably not talk about today because those are either more self-explanatory, such that you guys would catch them and refer them, or they're very, very sort of N of one idiosyncratic. And we're going to focus on the other two more common questions about head shape and head size that I think bedevil all of us. So let's start with the 3-month-old with abnormal head shape. What we're talking about. On the one hand, here's a young guy that I'm pretty familiar with reading his Artsy Cats book. And on the other hand, here's a kid in the operating room. This is, the head shape that I'm sure you guys have all seen a million times, of a little bit of positional molding. And on the other hand is a very profoundly scapulocephalic child who needs a correction for their sagittal craniosynostosis. So what's in between? Well, we're talking about disorders of sutures. So craniosynostosis refers to the early closure of the cranial growth plates or sutures. There are major sutures and minor sutures. For the purposes of this talk, we'll confine ourselves to major suture synostosis, which would be of the metopic, the coronal, the sagittal, and the lambdoid sutures. The metopic suture is the only suture that physiologically closes completely within the first year of life. Often, although it's on a spectrum in the first 3 months, the remainder of the sutures should always be visible and should not be closed until the late teenage years or even sometimes the 20s. They may not be growing, but you should be able to see them. There are also minor sutures: mendosal, occipitomastoid, squammal, frontal, squamosal, and sphenoesquamosal. So those are really well described in this AAP article by Mark Diaz and company, who did a really, really great job. So that's the 30,000-foot view. You've seen this chart, I'm sure, 1,000 times of here are all the different kinds of craniosynostosis that you can have. It's a really nice chart. I really don't like it because it doesn't look anything like what you see in a typical practice. So this is now going to show you over about 10,000 kids, which I think is a relatively reasonable amount of children that a pediatrician might see, perhaps in their career, maybe a little bit more. Maybe if you have a phenomenal practice, it might be a little bit more than that, but order of magnitude. So you'll see about 4,659 positional plagiocephalies. That's the highest incidence that we've seen in recent series. Almost 46.6% of kids have some degree of positional deformation, probably about 10 to 20% in more severe cases that we'd really be talking about in terms of real phenotypic abnormality. Only about half of the kids you see are truly normocephalic. You'll see a couple metopics, maybe a tenth of a lambdoid synostosis over the course of your careers, half of a bilateral coronal, which are extremely rare outside of syndromes, and probably about a single unilateral coronal craniosynostosis. So in essence, what we're saying is you're going to see 9,990 kids who have normal heads, and you're going to see 10 kids over the course of 30 years who have craniosynostosis. So if that were a procedure that I was performing in the operating room that I did once every 3 years, I would be very, very concerned about my ability to do that. And now I'm asking you guys to pick out that diagnosis every single time you see a newborn. So I have a tremendous amount of respect to you guys for picking this out. I want to communicate very clearly from the neurosurgery team and from our side that I don't think that there's a bad referral for craniosynostosis evaluation. I think that we're happy to see really any of the kids that you guys find relevant. If you scaled it, like one of those maps that actually shows the area accurately when I did this out, this is what your world would actually look like. And all we're talking about are these little tiny things, blips on the radar at the end of this. So here you have a kid. What's going on? The vertex is up, the nose is pointing straight up in the air. What's going on with this kid? Is this deformational positional plagiocephaly that we've seen, thousands and thousands of times? Is this a unilateral coronal craniosynostosis? Is this a unilateral lambdoid that we'll almost never see? How do we tell the difference? Well, when we look at the kid's face, it becomes a little bit more clear that there's something dysmorphic about the face. Now, you'll see some facial dysmorphism in the plagiocephalies as well, so don't let me take that away from them. But the things that you might be drawn to for this, you might want to look really carefully for ridges in kids who look abnormal. Ridges plus a cranial shape abnormality are very predictive of an overall craniosynostosis. You might want to look for eye and facial abnormalities, not just bulging of the forehead, but orbital and cranial base abnormalities. Those are highly predictive of having a craniosynostosis as compared to a plagiocephaly. So this ends up being the 1 in 10,000 of a unilateral craniosynostosis, coronal craniosynostosis that we see. And so what's at stake here? Well, which of these two operations would you prefer? On the left is a case we did this week, which is a great case. It's an open, about a 9-month-old correction of a unilateral coronal. And on the right is a case that I did earlier, which is a correction of a 3-month-old with a unilateral coronal through an incision that's about 3/4 of an inch in length. So on the left hand, the kid is still in the hospital. They'll stay in the ICU. They'll need a blood transfusion. They'll do really well. They'll get a great correction. On the right hand, there's a kid that'll go home tomorrow that won't stay in the ICU, that won't get a blood transfusion, who will be in a helmet for a few months and will tolerate that really well. So ultimately, what I want to communicate is those are both good outcomes. These are not kids who have elevated ICP unless they have other syndromes. But the earlier we catch them, the better they'll do. This is just some general content. I'll kind of breeze through this in the interest of time and lunch. But the point that I want to make on this slide, just to carry home, is that the timing of the diagnosis is important. The earlier that these kids are diagnosed within the first 2 to 3 months of life, that enables us to perform a minimal access surgical repair as opposed to an open reconstruction. Both get good results. This is just sort of a table that shows some of the differences between positional molding and craniosynostosis. We'll go through a couple of these just so that you've seen them and really for the content. This is a metopic. This has a classic trigonocephalic head shape. Again, the metopic physiologically closes around 6 months of age, but it's highly variable. We've all seen tons of kids where when you run your hand over their forehead, they have a little ridge in the middle. That is technically a metopic craniosynostosis, but that does not need surgery. That is not cosmetically disfiguring. That is not associated with elevated ICP. as opposed to the trigonocephalic kid that has a true sort of protrusion of the forehead, is going to have orbital abnormalities, and those are the reasons that we'll typically correct those. It's again rare for these kids to have true ICP problems, and these kids either need an endoscopic suturectomy early in life, where we just cut out the suture and let a helmet remodel their head, or frontal orbital advancement later on. This is the kid that we've seen earlier, forehead bulge, harlequin eye, the ridge, which I think is really useful in unicoronal craniosynostosis. The fontanelle's deviated over to the other side. So those are some of the tip-offs about the coronals. The nose and chin are deviated. So again, these are the things that should really be tipping you off for a coronal craniosynostosis, as opposed to positional molding or positional plagiocephaly. And this is what the marking of the suture, and then the one line in the middle here at that Stephanian area, that's at the lateral orbit, that's where we'll put our incision for that endoscopic approach. We probably think about this too much. Does this kid have bicoronal craniosynostosis, or do they just have brachycephaly? Brachycephaly is in those 4,000 kids that you'll see in your practice where the back of the head is flat, versus the kid on top with facial abnormalities, orbital abnormalities, and those are really the main problems. So as far as the sagittal kids, those are, as far as the sagittal kids, those are, kids who are scaphocephalic. They'll have a palpable ridge. If you push on the parietal bones, they'll stop moving. They'll be stuck together. And those are really the warning. But, I think these are good referrals whenever a kid has a significantly low cranial index, meaning that the head is very narrow. So a cranial index below 0.75, let's say. These are kids who will do really well with an endoscopic repair. It is familial in a small percentage of patients, so always good to ask about parents. Versus later on in life, we'll do an open procedure instead of these minimal access cases. We worry a lot about this, so I just wanted to show this slide about positional plagiocephaly, which you'll see 4,600 times in lambdoid craniosynostosis. The differentiation in my mind is the location of the parieto-occipital bulge and the contralateral location of the frontal bulge, the deviation of the ear coming back with the parieto-occipital bulge, and moving away from the frontal bulge. Right, so that's sort of my annotations, but that's how when I see these kids, recognize that this is deformational plagiocephaly and not a lambdoid synostosis, which is simply that, number one, there's no ridge, but in a lambdoid, you can't always feel that. From bossing, it's opposite from the occipital bossing, and I look at the ears from the top of the kid's head, and if the ear is coming back with the occipital bossing, then that's diagnostic of positional plagiocephaly, and I don't need to scan that kid. If the ear is moving forward away from that, then I'm concerned. So this is probably the mortal enemy of all pediatricians. This is what it looks like on a CT, just showing the absence of this lambdoid suture. This was incidentally found at age 4. This kid did not need surgery. There's a wide spectrum of lambdoid craniosynostosis. This is what the surgery would look like. It's a large vault, and just to show you kind of what these kids get their windswept appearance, and that's the reconstruction plan that we have to basically cut out the suture and then flatten out the bulge at this kid's age. I'm going to skip through some of the background positional plagiocephaly slides that you all know so well, just to say that this is a really, really, really huge problem. And we don't have good evidence in favor of our treatments. The only RCTs that were done actually were not favorable for helmets. The RCT about physical therapy in kids who have side preference is really important to highlight. Any kid who has a side preference should be strongly considered for an intervention for repositioning and for potentially physical therapy, especially if they have any sign of deformational plagiocephaly. Those kids do really well. They don't go on to need further interventions. As far as our national governing bodies and guidelines, they do sort of discount that larger RCT in favor of the many, many thousands of patients represented in our observational case series. And we do recommend helmet use for both a more rapid correction of positional deformation, as well as a greater overall degree of correction of positional deformation. This is something that I think a lot about. Are we really preventing cranial deformity, or are we monetizing patient and parental stress? I can't tell you how many parents I see who are kind of hand-wringing about this. So I actually looked at some of the policies on this for insurance companies. And it's interesting to me that if we, and this is something that I'm happy to do in my notes now that I've learned this, if we document the measurements, the actual degrees that are required from these companies, they may actually accept these as medically necessary, which was very unusual to me. I'm used to getting these rejected every single time. I don't know what your all's experience is with ever getting a helmet covered by insurance for positional molding, but I have really bad luck with that. So, this always makes me wonder, isn't there an app for that? So because we're here, I thought I would mention that there's one of my colleagues at Children's and a good friend, Marius Lingararu, has a company that's made a product called SoftSpot that actually will perform cranial measurements, will integrate within a pediatrician practice. I have no involvement in this company whatsoever. I've not used it, but it's an interesting concept of performing automated cranial measurements for kids with plagiocephaly or concern for positional molding. So that's something that is available, and I think we'll see a lot more of these AI-enabled apps in the future. In summary, we'll pause after this point just in the interest of time. Regarding the craniosynostosis issue, early referrals are good. There's no bad referral for craniosynostosis. When you're looking to catch your one lambdoid that you'll see in your career, and honestly, even as the tertiary quaternary center, we don't see 100 lambdoids a year. We'll see operatively a few, really a handful. In positional plagiocephaly, you're looking for that opposite bulge and opposite shift anteriorly. If the parietal bulge is getting worse after 6 months, that's unexpected. That should be getting better, and that should prompt those kids to be considered for further evaluation. Keep looking at these kids who are in helmets who are doing badly. Those are the important kids that we may need to see later. As far as interventions, we discussed that there's some strong evidence in favor of physical therapy for kids with side preferences, that helmets may be effective, although, we do have to note that there is a randomized controlled trial that did not favor helmet use, that did not show benefit, but that these are really expensive. They're worn 23 hours a day. And again, in my experience, although I've now learned and I'm working on it, it's not well covered by insurance. We'll, in the interests of time, move just very briefly through these concepts. Just showing you these 3 kids with big heads. And I'm just curious about a show of hands. Which of these, who thinks that the girl on the left has hydrocephalus? Any takers? Perfect. What about the young child in the middle? What about the boy in the orange shirt on the right? Excellent. So I did this to be representative of our practice. 0 of those kids have hydrocephalus. They're all from the Benign Extraaxial Collections, Benign Enlarged Subarachnoid Spaces Facebook group, which apparently just posts pictures of these kids until the cows come home. It's a little terrifying, but here we are. That's what their parents have put on the internet. I know, right? So I would be significantly worried about her for a cranial shape disorder, right? For a craniosynostosis or a need for ophthalmologic evaluation. So I think that's a good pickup, but this is the mom's diagnosis. So what are we really talking about? This is probably the most impressive case, that I've seen of a benign enlargement of subarachnoid spaces. It's a benign finding. It's due to disorder in relative CSF absorption. It's important to note for the following reason. If I can make you believe, all of these little lines in this axial T2 weighted MRI are veins, right? And they're running through these fluid collections in the subarachnoid space because they got to get to the brain. They got to come from the surface of the dura. Those can tear really easily. It does not take trauma to cause a subdural hematoma in a kid with benign enlarged subarachnoid spaces. So we do not consider subdural hematomas, unilateral or bilateral, pathognomonic for abusive head trauma and physical child abuse in this population. That's probably the most important reason to establish this as a potential medical diagnosis, which can be done by a cranial ultrasound just showing on the left. We don't even need to get a fancy MRI, although it's very nice for us to really, sometimes you can see the vessels, sometimes you can't. But kids with an open fontanelle, it's, this can be a service to the family, just a summary table. About 1 in 20 of these kids will get some subdural collection. So, again, this is about separating out the dangerous ones, who should get a scan. Again, looking at these papers and numbers, I have a tremendous amount of respect for the pediatrician community, right? Of the 75,000 kids in an integrated healthcare system, 233 had benign large subarachnoid spaces, maybe 24 had hydrocephalus and a few others. It's very difficult to pick up hydrocephalus or benign large subarachnoid spaces on head circumference measurements because of the high rate of normal kids who have heads in the 90th percentile, right? About 10%. Now, the best screening measures that we had in terms of specificity were large relative increases crossing 4 major percentiles on our WHO charts, or large absolute increases in head circumference above the 95th to 97th percentile. But this is really tricky. The other thing that I thought that's useful to note is the sort of trajectory of how these kids do before they're diagnosed with acquired head hydrocephalus, that they're actually fairly quiescent. They'll have some minimal increases, which is why it's quite relevant to keep screening these kids, monthly, as I know you guys all do. So I'll end with this. So the question is, when is a normal head circumference not normal? This is a kid I saw in my clinic. They're an X30-week with bilateral grade 4s. And they come in with this head circumference measurement. It's at the 50th percentile. Okay, yeah, sounds good. I look back, saw a cranial ultrasound. Okay, those ventricles don't look so bad. What's going on with this kid? Why are they here, right? Then we look back at the prior head circumference measurements. We said, oh, this is quite different, right? This is a kid who was a 0th percentile head, and now they're a 50th percentile head. So they've crossed all these percentiles. By the time we get imaging, they're here and they look like that. We got a shunt. Kid's doing great. Post-op day 1 from the shunt. I'm talking to mom and she's like, I had no idea my kid could be awake like this. The kid was just sitting at home, not doing anything. And then now she's a little bit of a terror, but that's okay. So this was my take home, is something that you guys all do so well, which is trending head circumferences and not being reassured by normal head circumferences in kids who had initially very abnormal, small heads, preemie NICU kids that are sent to your practice. That those are kids who should be followed kind of closely and carefully. So this kind of summarizes the hydrocephalus piece of it. I'm going to pause here. We're not going to really get into the treatments of hydrocephalus. Of course, there's shunts and other options that we have as well from the surgical side. I've left some information here about intracranial mass lesion warning signs, which are what you guys would all expect. Headaches are essentially never an intracranial pressure problem unless they are accompanied with danger signs that we've listed here. Again, this is the same problem that we talked about before, of how many kids in your practice have headaches versus how many kids in your practice have brain tumors. But these are the important signs and their relative presence in the population. So, and this is a sort of a proposed imaging strategy of how to manage the well child with headaches that I'm sure you're familiar with. So these are those papers that I mentioned from AAP that I thought were excellent, and this is sort of the 30-word summary. And if I wanted to put this in fewer than 10 words, I'd say one of my favorite movies. There's a line that says, if there's a doubt, there's no doubt. So if you're worried about a kid, if you think there might be something wrong, we're always happy to see them, and you should call us. So this is some of the ways you can get in touch with me and, of course, with our team. Thank you guys all for your patience. Thank you very much.